Sorry, I was supposed to present first, and then speed to here, and then got pulled over. But I played the doctor card. I said, I'm a doctor, I'm late. Didn't work. So here I am. Sorry for being late. I was supposed to present first. So welcome. We'll talk about medical management with the heart team perspective. Basically, what needs being done is organizing care in your own single hospital. And it involves the interventional cardiologist, of course, but also the transplant team, the heart failure specialist, especially if the patient is slowly degrading and could be a candidate for heart transplantation. The nurse and social workers need to be involved, especially if you think about destination therapy versus transplant. And obviously, perfusionists are essential in the discussion, in my opinion, and obviously cardiac surgeon or thoracic surgeons. These teams need to work together and insist on the team valorization, not own service valorization, and their efficacy needs to be assessed as a team and not as individual. And this is very important and possibly the greatest challenge of all for heart team approaches, because most cases are urgent or emergent, and there's little room for negotiation about who does what. And it needs to be clear that what are the long-term goals depending on medical therapy and surgery, if something can be fixed, LVADs or heart transplantation. So do not hesitate, escalate. I think it's the message. Do not wait hours, but wait an hour. I guess this is the way to go. This is a goat. And there's an interesting story behind this goat. And it talks to the concept of heart team. Whenever I talk to surgeons about heart team, they insist on the fact that my great-grandfather stole a goat to their great-grandfather. And then when I come back to my very own team of interventional cardiologists, they remind me that this is not exactly the story, that the goat was desperate and lost and needed help for milking. And so I think it illustrates the importance of going against not the goat, but the big cheese. And this is, of course, the wheel of cheese. You're all aware of this Gloucestershire, whatever you say it in English. The cheese, the wheel of cheese. And I think this is the importance of working as a team to go for the big cheese. And certainly organizing shock team is no exception to this rule. And I think you can see a bunch of surgeons falling on the right side, and then, of course, the interventional cardiologist is going for the cheese. So the possible scenarios are in where you might be called to assist for LV support and or cardiogenic shock are witness cardiac arrest or immediate CPR, as alluded by Johan previously, but you also have the post-MI shock with stunning and mechanical complications. You have the old good acute fulminant myocarditis, which can or may not respond to initial therapy. You have the slowly but surely decompensating LV dysfunction that will require eventually assistance. And then that may or may not be decompensated by an intervention such as ICD implantation or an attempt at PCI. You have the growing market of acute right ventricular failure that may involve post-extracorporeal circulation, pulmonary embolism, but also post-transplant. And of course, you have the electric storm, which also could be helped with medical management. And what would be a good medical management presentation without pressure volume curves? So you know the curves, but essentially the idea is to maintain or generate stroke work with the heart. So if you think about the different principles to help a patient with cardiogenic shock, you may increase preload, increase afterload, increase contractility or inotropy, or improve compliance. In my opinion, the only way to improve compliance is unloading the ventricle with an assist device. There's no other way to get out of this compliance issue with medical therapy alone. So at steady state, you generate a certain stroke work. During an acute myocardial infarction, you will see a reduction of your output, essentially because of increased compliance, but also decreased inotropy. And during the cardiogenic shock, which is the extreme phenotype, the compliance is also increased. The heart rate is what maintains an output on these patients. And the idea to unload the ventricle to get out of this cycle and maintain reasonable oxygen consumption is to decrease the wall tension, the stroke work, oxygen consumption, but also maintain output. So how to choose the best support device, this has been reviewed. So SID as a wrap-up, depending on the etiology of refractory failure. And there are tools that can be used in the cath lab by the interventional cardiologist to help sort out which device or where to direct the patient. And we'll talk about it in a minute. So say your patient has a cardiopulmonary failure with mostly RV failure. You can think about a right atrium, left atrium ECMO. This is surgical consideration. For cardiac, pure cardiac failure, then oxygenation may not be necessary. It may be desirable, but may not be necessary. And if you have RV and LV failure, you'll choose the device accordingly. But you need to be able to sort out immediately whether your patient has a right ventricle failure or not. And then if you have exclusively pulmonary failure, you can take RADS or severe pulmonary embolism that compromises ventilation and not necessarily flow. You may consider BIV ECMO or VV ECMO. I was going to say VA ECMO or VV ECMO for these patients. And I guess this is the magic formula we use most of the time at the Montreal Heart to, in the cath lab, you receive this patient in shock, you're not sure what's going on, there are several possible presentations. I guess as interventional cardiologist, for the initial medical management, you can put a swan in or you can do your right heart catheterization to tell whether there's a RV failure or not. And the most reliable index in the literature is a right ventricular stroke work index, which essentially means the mean pulmonary artery pressure divided minus the mean central venous pressure, multiplied by stroke volume and divided by body surface area. Essentially, the stroke volume index is the cardiac index divided by the heart rate. And those patients with a value above 900 will do just fine with left ventricular assistance. They will not need combined right and left assistance. It gets gray when you're between 900 and 600, where it's not clear whether the right ventricle will fail if you put a standalone LV assistance device, whereas if you're below 300, you need to consider biventricular assistance, and ECMO would be your solution. So in terms of solution, you've reviewed the solution, so I'm not gonna spend much time on it. But so in case of not so urgent intervention, and I know Ong will talk or ask, have you talked yet, Ong? No, we'll talk about this, so I'm not gonna insist much. I'm really late, I'm sorry again. So the IRIS PCI, as a heart team, and Ong will get into the details, but you need to discuss treatment option, and most important, you need to have an exit plan if it doesn't work, and hence the importance of involving the surgeon from the get-go. And then, of course, the handling of the vascular access, especially if you're using large bore cannulae above 15 French. For the urgent consideration, what you might want to consider in your early medical therapy is distill whether it's an ECPR condition, so witness cardiac arrest outside of hospital, if it's an electric storm or a cardiogenic shock. And in case of ECPR, Johan has presented our indication. So the decision to go with 65, Stefan, was based on mostly the experience at La Pitié in France, where few patients survive when they were above 65 in their 100 patients. So there were almost no survival. And so in the consideration of the early program, we decided to go with 65 to get the best possible result, and then broaden our indication if we were to get good success, because as any other institution, we had to convince administration that it was doable. So age below 65 is arbitrary, but it seems to be worked just fine as presented by Johan here. And then we totally will decide if we go or we don't, based on expired CO2 or the lactates. The magic number is 13. If we're below 13 with expired CO2, we're not going to go for the ECMO. And if the lactates, they're rarely available, but ETCO2 is always available after intubation. So, and then, of course, if there are considerations such outside business hours, you may want to reconsider ECMO because of delays. In case of the electric storm, the consideration is even more interesting because I enjoy very much the idea of wakening my electrophysiologist colleague at 3 a.m. in the morning, and I think it's a good feeling to do it. The decision needs to be according to the presumptive defective pathway. So will you need to unload the ventricle? So do you think that the stretching of the left ventricle is involved in the arrhythmia? Because you have these epicardial arrhythmia that may not necessarily be triggered by LV stretching. And then in such a case, tandem heart and impella might irritate the left ventricle. May not be a good idea. So you need to consider what you're going to do with your 5 French impella in the apex. Is it going to help or not? So you also need to consider whether ischemia is a big factor. In such case, the old good intra-aortic balloon pump might be the solution, because to my knowledge, it remains a very good technique to improve coronary perfusion. And then the other question is there a shock or not? And if there's a shock, then you need to consider support the LV dysfunction. And of course, do not hesitate to wake your EP colleague. I think they need to be part of the solution. So in case of cardiogenic shock, depending, this doesn't come right, but I'm sorry about the quality of the imaging here, but you need to consider whether there's a biventricular failure, in which case you will select VA ECMO. If there's a unique LV failure, then rule out the presence of a left ventricular thrombus, arrhythmia, or aortic stenosis, and then choose accordingly. And then in case of right ventricular failure, we have very little experience at the Montreal Heart, for instance. But I know, for instance, I think the RP system is available here in McGill, if I'm right. So perhaps Stefan can comment on it. But you could use the very promising devices there as well to support the RV failure. So I guess I'm going to stop here and then take question if it's okay. Yeah.
Absolutely. Thank you, Marc, for this presentation. So, thank you.